Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day. While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yep, absolutely. And welcome aboard. We're so glad to have you with us. We hope that you spend the next hour with us and that you will consider it time well spent. We've been doing the show for a while. We zero in on case studies sometimes. That's what we're going to do again this week. And, you know, by the way, if we don't mention something that you're concerned about this time, don't worry, we will next time. And you can always go to the www and check out veinclinicsofhawaii.com. And look on previous shows, look on things that are happening, and look at the events, and look at some of the comments, some of the great testimonials that you'll see there. Dr. Juliff and I have been doing this show for several months and have come across a bunch of things. And one of the things that I really like is when we get into some of the more, I would say, I don't want to say end game, but more at the upper spectrum. This is kind of a long introduction, Doc, but what I'm saying is that I've learned through you that there are about 6 stages of venous disease, from very, very, you know, what do we call it? Spider vein stage?
Right.
And then it goes up on till you get to number 6.
Continuum, yeah.
Yeah. Now, the difference between 1 and 2 is, and 2 and 3 and 3 and 4, not that much. But when you get to the upper stages, it's a major leap. In other words, it's serious.
Yeah, probably stage 4 is where it really gets kind of concerning. But yeah,
good news is that not everybody that has venous disease gets to stage 4.
That is good news.
That's good news.
And the other good news is that you know, even if you have reached that stage 4 level of venous insufficiency, we still have pretty easily correctable of procedures that we can do, and people tolerate it very well.
I remember the song "Turn Back the Hands of Time." Turning them all the way back is kind of difficult no matter what you are.
Very hard.
But if you can just actually, in many respects, and I've looked at this from many which ways, because not gang only am I the host of the show, Dr. Juliff, but I'm a patient. And I've had a lot of work done, and I do know that the quality of life that I enjoy, pounding around on fishing boats and offshore fishing and doing all the things that I like to do, walking and all kinds of stuff, wouldn't have been possible had I not had those two very important things worked on called my legs.
Right. Well, you know, we use our legs a lot for a lot of different reasons.
So today, one of the things that, and this really got confusing, when I first learned about these things called ulcers a long time ago, I was like many people, and Docky, you even told me this, you know, most people when you say ulcer think, oh, poor guy needs Pepto-Bismol because he's got a hole in his stomach.
Right.
You know, because that's what we all think ulcers are.
I think most people, when they hear the word ulcer, that's what they think.
What is a leg ulcer?
You know, a leg ulcer is kind of the same thing. The same thing as an ulcer in your stomach. Mm-hmm. You know, an ulcer in the stomach basically is just a deterioration or a breakdown of the inner lining of the stomach. Mm-hmm. You know, those surface cells. And you know, when you look at when you look through a scope or whatever at a stomach ulcer, that's what it looks like. It's a little punched out area where it's, you know, red and raw in the middle, and the normal, you know, inner layer of the stomach is not there anymore. And that's exactly what happens on your legs.
Does it go through the stomach?
Well, sometimes it can.
Yeah. Sometimes
it can. Luckily, that doesn't happen in our legs.
Yeah.
It doesn't all go all the way through.
However, I must tell you that for many people, the process of elimination that we're going to discuss today is not the first one they take. Because a lot of people, they look at that thing, they continually put, you know, an antibiotic cream on it for 6 months, thinking it's going to go away, and they just don't. How come?
Yeah, well, because there's an underlying problem. Mm-hmm. Yeah, and it often has to do with vein function. But I think in ulcers in general, on our legs are one of those things that people don't necessarily connect with vein disease. People who have varicose veins or spider veins, that kind of thing. I mean, it's an easy connection. They see that on their leg and they say, oh, yeah, I've got a vein problem. But people who have chronic swelling and skin changes that we're going to talk about and ulceration, the first thing that pops into their mind is not that there's a problem with their circulation. So consequently, they treat it locally. They treat it with topical ointments or whatever. And then the even more confusing thing is that sometimes those ulcers will heal with that type of therapy, but invariably they come back if you haven't addressed that underlying vein problem.
Yeah, and by the way, when you say healing, I do know that there's several different levels of healing. One can be a very thin membrane that you think, oh, I'm healed. Right. Because it's covered.
Yes.
But in actual fact, it's really not, is it?
Yeah. You're right. I mean, the initial stages of healing, we see ingrowth of skin, skin cells. And, at some point it's completely covered with that initial layer of skin cells. But that initial layer is very fragile and easily injured or broken down until it gets to be fully healed.
Okay, well, as you know, we try to zero in and speak about an individual. A lot of what we do here, by the way, is it's class-wide. It'll affect lots and lots of people. Today, although some of these things affect lots and lots of people, we're really dealing with one guy, and this one guy is quite a case.
Yeah. He definitely had advanced form of venous insufficiency, but this patient was a 68-year-old gentleman who came into our office about a year and a half ago, and probably he came in primarily because of swelling, and the swelling was so severe that he was actually having fluid seeping or weeping from his skin, and it became a problem for him, just managing it. And sometimes that happens. The edema gets so bad that the skin is actually not able to keep it, within the soft tissue of the leg, and it comes out.
When that happens, and we'll talk about this, guys, as time goes along today, can that happen like daily? I mean, does it? Does it sometimes go away for a little while, then come back a little bit?
It can come and go. And it's sort of based on the amount of swelling that they have at any point, particular point in the day. Often you'll go to bed at night. If the patient is lying flat in bed, then a lot of that swelling will go down, and maybe the weeping will stop. And then they're up the next morning and maybe going to work, or they're on their feet all day for whatever reason, and then the edema collects and the fluid starts to come out again.
Yeah, and by the way, gang, there's so many different reasons why we do the show. One of them, it's obviously your health is important, but your quality of life and your ability to continue. One of the things that we all notice now is that, hey, it's pretty expensive to retire, so there's a lot of people that are taking additional work on, and maybe they haven't worked on their feet for a long time because they've been an executive or whatever, and now they're passing out goodies at a store, or they're greeting people at a store, and all of a sudden they're on their legs for 6-8 hours a day, and they start getting some issues.
Right.
Yeah, so this guy's 68.
He's 68. And I don't recall whether he was still no, he was retired. He was retired. But he had swelling from the ankle to about the knee, so the entire lower leg. He also had something that was very typical in advanced venous insufficiency, and that is a brownish discoloration of the calf.
Of the calf.
The skin. And it came about 2/3 of the way up. So it was, 2/3 of the way up to the knee. So that's a fairly significant amount of discoloration, and certainly a sign of venous insufficiency at an advanced stage.
Can it also be a sign of diabetes?
Typically not, although a lot of people kind of write off the brownish discoloration because they have diabetes or high blood pressure, or they're out in the sun.
Yeah, that's
much.
What I was getting at. How many people just minimize what that is because they think it's part of something else?
Or they inherited it from because their father looked like that or whatever. But the discoloration is something that people write off very easily. And again, that's one of those symptoms that is not well known. known with respect to its connection to vein problems.
I probably ought to meet the guy because I was under the mistaken impression years ago, because you try to justify something. Once again, I think it was my granddaughter says, "Hey, Papa, why are your feet red?"
Yeah.
Oh, because I was fishing today. It's sunburn.
Right.
It wasn't.
No.
So, but aren't we all just looking for some deductive answer? What is that? Well, I was outside all day. Must be sunburn.
Sure.
Or I must be allergic to something.
Right.
Yeah.
I think a lot of people do that.
Yeah. So this guy was the first time he rolled into your office at 68 years of age.
He was 68 when he came in. Yeah. So as I recall, he had not really had these problems addressed before that. So it was.
So we had some catch up to do with this guy.
Yeah, very typical story where he was ignoring the symptoms and the signs for quite a while, but his skin was also, not only was it discolored, but it was also thickened and in kind of sort of a rough surface to the skin, kind of a fibrotic feeling to it, and that's another one of those signs of chronic venous insufficiency, something that we call lipodermatosclerosis.
I saw this guy the other day, and I was wondering about that. I'm going to have to add that to my repertoire, just so I sound like I know what I'm talking about. This guy had skin that looked rough, but it also looked cracked, like when you see the floor of a desert, and it's got those cracks from arid or from a drought. It looked like leather that was cracking. Yeah,
and his legs were swollen.
Very.
Yeah. That could be one appearance. Sure. Yeah, absolutely.
It was actually, to be honest, on a field trip I did with a homeless shelter to get into the field and do some field work. And this guy was literally hamstrung to his location because he just couldn't move around. He had all these issues with his legs.
Right. Yeah. It can get that bad.
But this guy wasn't that bad, but he certainly was looking for some help.
He was ambulatory, and but it obviously affected his quality of life, if for no other reason because of the fluid that he was trying to manage with dressings, etc. But he also had scattered varicose veins, mainly in the upper thigh portion, the inner thigh on the left, and then on the right he had a fairly larger complex of varicose veins that were on the front of the thigh, and then they sort of wrapped around the outside of the leg, which is kind of a typical pattern. And most notably on the exam, he had a large flat ulcer with an irregular border, and it measured about 6 by 4 centimeters. Which is, 2.5, 3 inches.
Yeah, and by the way, friends, when you take a look at these ulcers, when you think of stomach ulcer, like Doc was said, you're looking at something that can be as big as the eraser of a pencil or get quite large. On the legs, these things, that's pretty big, 3 inches.
Yeah, well, I was just going to say, that's sort of a moderate-sized ulcer. Actually, I mean, some folks come in that have had ulcers for months and months, and they can be very large. We've talked about the gator area of the leg. Yeah,
that gator, by the way, is below half calf and above the ankle.
And they sometimes an ulcer can occur that is virtually circumferential all the way around the leg.
We actually had a case study like that at one time that we talked with a lady that had that, and gone out of her way to make sure that nobody else saw it.
Sure.
But just thought it was going to somehow go away on its own for a long time.
Yeah.
Are you sometimes amazed how long some people will put up or tolerate with something?
That's always surprising to me. But that's a very common approach. I mean, people, they want it to go away spontaneously, but some things don't. Some things have an underlying reason that's not apparent, and you have to kind of fish through it. He had a pretty good size ulcer, and located on the inside of the right ankle. He had, again, discoloration, swelling, abnormal skin. All of these things were a fair bit more pronounced on the left. He had the ulcer on the left. The right leg also had the discoloration, but no ulcer. And that's pretty typical, where we see, one leg to be a fair bit more advanced, I guess, in the process. And basically, it's just they're on a different point of the timeline of how venous disease evolves, over a long period of time.
And gang, one of the important things you can do to check out what we're talking about is go look at the Vein Clinics of Hawaii website. It's veinclinicsofhawaii.com, and you're going to see what we're talking about here. Not specifically this guy, but that condition. And I think when you start doing the examination, I do know that there's several critical areas where you need to get a positive response, and if you don't, it's indicative of a problem. What are some of the things that you use in diagnosing what the treatment might be for this ulcer, this venous ulcer?
Well, in him, I mean, he definitely had a venous origin, and we'll get to that. And typically we sort that out with ultrasound. But the first thing we do is physical examination, and just from his physical examination, the arrows are pointing in the direction of venous disease. He had strong pulses in his feet.
What's that? Why is that good?
We palpate, we palpate, or we feel for pulses in the feet. There's two different locations, and if we feel strong pulses, which he had, we are sort of, it sort of implies that the arterial supply, the blood getting down to the foot is fine, and we don't necessarily have to look into that any further. But whenever somebody has an ulcer on the lower part of their leg, there's a number of different reasons why they might have that ulcer. One of them is vein disease. Now, vein disease is the most common reason why somebody might have ulceration on their leg. But a lack of blood flow, something that we call peripheral arterial disease, that can also be a cause for ulceration. People with diabetes can also, often have ulceration of the feet. But each of those ulcers, each of those types of ulcers has a very typical kind of appearance. And you can, just from looking at them, usually you can tell why or the reason. Yeah. And again, the venous ulcers they can be pretty large. They're usually relatively flat. They have an irregular border, as opposed to diabetic ulcers that are very kind of punched out in appearance. It was pretty obvious for this guy that he had so many things pointing in the direction of chronic venous insufficiency.
What sort of rationale or what sort of reaction was he giving? I mean, obviously, I learned from some of the stuff you sent me, he blames family. And I'm sure we all do,
right?
And with probably with every right to do so, because most of this, thanks a lot, Mom and Dad, we got from you. Some of it definitely was from our parents. But however, that may give you a false sense of security, and maybe for a long time.
And he did have that. That was part of his story coming in. He said, well, he's always had big legs, and he wrote it off to family because his father also had big legs, and probably his father had some discoloration of his skin too, and made it look like his father's legs. And probably, you're right. The father probably had venous insufficiency.
Well, I talked to this one guy. Says, both my Uncle Biggie and my Uncle Fatso have those legs. So, I mean, this is what they. Unfortunately, a lot of these people just relegated to they can't do anything about it. But you are finding more and more of these people that, au contraire, you can do something and do something about it.
And that's the message that we try to get out to people. The condition can be improved upon, but over a period of time. I mean, he stated that even when he was young, he had big legs, but in recent years, he did note that he was starting to have other symptoms like achiness, heaviness, fatigue. Legs getting tired quicker than they used to. He stated that luckily he was retired because of the way that his legs felt. He didn't feel that he could go back to the job that he was, or be able to do the job that he was doing previously.
Yeah, and I hear this, gang, on my regular show all the time. People looking for something to do. And right now we're fully employed. I mean, employment's at an all-time high. And however, now there are still people that are saying, okay, well, I'm going to volunteer. I'm going to do something because moving around is the best medicine. And if you're not able to move around,
Right.
you're likely to go and get some help and say, I want to volunteer, or I want to do this, or I want to do that. What can we do to me? I don't want to stay home all day.
Sure.
Yeah.
Yeah, I mean, leg health, I mean, is not only is it healthy for your body, but it's important for your overall body to be able to stay healthy, and we hear that all the time,
Sure.
But so he had, he kind of wrote off the brownish discoloration from working outside. He was in construction. His mother had varicose veins, but never had anything done with them. And here again is this misconception that, varicose veins are primarily a cosmetic problem and, don't necessarily have to be addressed. His mother didn't address, of course, that was a generation before him. And he just kind of ignored that part of it and was, chalking up these other symptoms and whatever to heredity, and didn't really feel like he had to pursue it too aggressively. The ulcer had been the ulcer that he came in with was actually his second ulcer, and again, this pattern is pretty common. He had a smaller ulcer in that same area, I think, a couple years before he came in, and he treated it, like we talked about,
sure,
antibiotic ointment,
whatever,
and some bandages, and with time it went away, but about 6 months later it recurred. And that is so typical of venous ulceration, which is another thing that people need to know, that if you have an ulcer on your leg and it takes a prolonged period to heal, and usually we think about 4 weeks. If in 4 weeks there is an obvious healing process going on, then there is something amiss. But sometimes these things take several months, but they finally do get healed. But eventually they come back.
Now, do they come back in the same place or near? Or maybe more than, or maybe both.
It could be either. Be either. But I think the more typical story is they come back in the same place.
Right. Which must make it going back at that even more difficult to heal.
Well, I think with time, as the process is evolving even further, then they're developing more venous insufficiency as time is evolving, and that makes it less likely that subsequent ulcer is going to heal.
Yeah, what I was getting at is my question really would have been using the same method of healing it. Maybe just pointing out to the fact that it didn't work last time, So we got to go to what's plan B?
Well, and that's what he decided.
Yeah.
He decided that my home remedy didn't make it happen, so I need to go find some help.
Sometimes chicken soup doesn't do it for everything, right?
No.
Okay. Oh boy. Okay. So now that must mean that he's getting more aggressive. He's seeking you out.
So he came in.
He's trying to do something.
Right. Yeah. And that's the most important step right there. Is calling the office and making an appointment to come in. And so even before doing any diagnostic testing in this guy, it was pretty apparent that what was going on. I mean, he had sort of a classic appearance, a classic picture, and a classic story for venous insufficiency. And he had all the things that kind of went along with it. He had a strong family history. His mother had varicose veins. His father had something. I mean, he talked about his father's legs being large and dark. So, I mean, I'm sure that he had something going on there. He had the ulcer and, other signs and symptoms of chronic venous insufficiency. The skin changes were very typical for venous insufficiency. So, we were dealing, obviously, with a presumptive diagnosis.
Yeah, and by the way, gang, if you've heard in the past of us talking about the Unabut, I learned this is a guy which was the perfect candidate for that. And even though it may seem cumbersome and uncomfortable or whatever, it's their success. You can't deny that they work. Yeah. So at what point in time did you give the guy the good news about the Unabut?
That was almost immediately.
Okay.
Because we want to make a diagnosis, but in somebody like this, it's very important to address the swelling immediately, because not only is the swelling and the weeping that he was having from the swelling a problem for his day-to-day existence, but it's the ulcer will not heal until the edema is controlled. Until the swelling
there you
is
go.
controlled.
This is important, gang. Realize this.
So, and there's a number of different ways that we end up, trying to control that swelling. So one of the quickest and easiest ways is to, use an Uniboot, and we started Uniboot applications with him right away. Yeah, so, we put the Uniboot. For those who haven't heard it described
this is not
before.
something you ride a bicycle with or a horse with.
No, it's not an actual boot. It's just a medicated wrap that we put on. It looks almost like an ACE bandage, but it's got a medication impregnated into it. And some are silver-based, some are calamine-based, etc. But probably the most, it's not the medication, actually, that gets the ulcer to begin to heal. The more important part of it is getting rid of the swelling, because the Uniboot is a wrap in such a way that it really does a great job with getting rid of the swelling over a relatively short period of time. So we apply these boots or these wraps, and typically we put a new one on every 2 times a week. So the inconvenient part of it is, number one, we put it on and it stays on, so the patient can't get it wet. Yeah,
let's think about lying down and sleeping. Are they uncomfortable? All that stuff.
So, and then the other thing is that we like to have them come back twice a week for us to remove the Uniboot, take a look at, assess what's going on with the leg and with the ulcer, and we repeat that again a couple times a week. So it's a little inconvenient for people to come back and forth, but in the long run, it's a good thing, because ultimately it will end up getting this thing healed.
I was going to say the success of this is it's borderline miraculous. Really, I mean, seriously.
Yeah.
This takes it from the very worst to manageable, doesn't it?
Yeah, exactly. Yeah, manageable, and we see initial stages of healing starting. So and also, once that initial swelling that he came in with, once that starts to be improved, then he doesn't have to deal with all the weeping and the seeping of fluid through his leg and the ulcer and all that sort of thing. So addressing the swelling again is the immediate thing. Now, are we thinking about making a diagnosis? Well, yeah, sure. We do that with ultrasound. But the swelling, especially in a patient like this, the amount of swelling that he had actually interferes with our ability to get a high-quality ultrasound and make the diagnosis.
Okay, so the commitment that was made, how long did he need the Uniboot part of the treatment?
That varies. It kind of depends on how they respond. But
I mean, in this guy, I mean, what sort of a course did he have?
We did Uniboot applications on him for 2 to 3 weeks.
Okay. Yeah, and that's a pretty lot, isn't it?
Yeah, that's a fair amount of time. Now, do we have people in Uniboots longer than that? Oh, yeah, there's no question about that. And that's something, Uniboots are nice because you can use it to treat, this sort of situation as long as you have to. But the first step is getting the leg to the point where the edema has resolved such that we can do a good quality ultrasound, find out what's going on.
And I'm thinking the patient already is starting to feel a little bit better.
One of the byproducts of the Uniboot also is that the leg does start to feel better. Yeah. A lot of people, some don't have pain with a venous ulcer, but many do. Yeah. And the people who do have pain under a venous ulceration, it can be pretty severe.
I got to tell you, gang, I had this treatment myself, and I can tell you that the pain and suffering is well worth. Once you can start doing the things that you want to do, and I do know that it's different, a little bit different for everybody else, but most of the things that people object to is the look of something or the feel of something. Yeah. But the benefits far outweigh the discomfort.
Well, in this situation, it absolutely does. But we find that even people with severe pain in the base of that ulcer, after we start the Uniboot and get rid of some of that swelling and cover that ulcer with this medicated wrap, they actually start to, the pain part of it starts to resolve pretty quickly.
Yeah, that's great.
So that is, and I'm always happy when I see that because it makes the patient feel so much better.
It must become like wait a minute, this doesn't hurt.
Yeah.
Good morning,
Oh, yeah.
this one doesn't hurt today.
At that point, they become happy that you've, asked them to have a wrap that they're not going to take off, and they're going to have to come in, twice a week to have it changed. But yeah, it can be very, very beneficial. So the next thing is, if there's a question of arterial insufficiency, we talked about the fact that this guy had good pulses, so we weren't concerned about the amount of blood getting down to his foot. We were more concerned about his venous state. But if we were concerned about arterial insufficiency, in making sure that wasn't the reason or a part of the reason, some people have a couple of different reasons for ulceration. I think that most of the time, and surprisingly, actually, people have either, the venous side of it or the arterial side of it. But sometimes it is a combined sort of picture, and we have to make sure that the arterial part of it isn't severe enough to address before we then address the venous, because typically if somebody has an arterial problem, we're going to attack that first. Okay. Before we
is
do
that what
the
you
venous
did what you did with this guy?
No, he didn't. Like I said before, he had very good pulses. His feet were warm. Capillary refill that we've talked about before is good, and so we didn't really have any suspicion that it was arterial. So we did a venous duplex ultrasound to look at vein function, and not surprisingly, he did have a significant amount of venous insufficiency. He had significant reflux in all of the axial veins in the superficial system, the greater saphenous vein and the small saphenous vein. And in addition, he had reflux in what is referred to as an anterior accessory vein.
Oh, boy.
And that was on the right side. That was on the side of his ulcer. So he just had, additional reflux. Accessory veins we've mentioned before, and those are just, they're kind of extra veins. Some people have them, some people don't. And some people have them in one leg and not the other.
Sounds like, in this case, it was an irritant.
Yeah, it was definitely adding to his problem.
Yeah, okay.
So that's what we found on the venous ultrasound. So what did we do? Well, we did the usual. We did radio frequency ablation of the refluxing veins to close them down.
Okay, when we're talking about that, gang, that's one of the procedures. That's vascular surgery. What you're doing is you're going in. You're going into that vein and knocking it out.
Right. Yeah, we thread a tiny little catheter into the vein. And it is surgery, but it's very minimally invasive.
Yeah, what we call walk in, walk out. The guys get out of there the same day.
Sure. Yeah, we don't make any incisions. We don't do any surgical vein stripping the way we used to a long time ago. But these procedures are all very well easily tolerated by patients. But we use this radiofrequency catheter. This radiofrequency catheter heats up the inside of the vein and closes the vein down.
Yeah, gone. Yeah.
And so then
and we do this, why?
That forces your body to reroute the blood, in that vein that's not functioning properly.
Find another way.
The blood, the blood is going in the wrong direction, so that's what creates the problem.
Sure.
The blood is going down, it should be going up. So we close that vein down, and that forces your body to reroute the blood to normal veins, and they come back, and then the blood comes back up to the heart the way that it should, and it relieves that abnormal flow of blood going downward, and in addition, that abnormal hypertensive sort of state of the venous system of the leg, which is causing the swelling and the skin changes and the ulceration, etc.
Okay, here's the thing that I love. It seems to me now that what you're going to do is dangle the "you will do this" or.
Yeah.
I've had the Uniboot. I'm talking out of school here. Let's say I did the Uniboot under a flag of protest. I did find out that there's I think it's called a 13-gallon garbage bag for your kitchen that works really well over this thing.
Yeah.
But once that's done, if you don't want to revisit that, there's an alternative, which is a lot simpler. And that's to wear those doggone stockings.
Yeah.
Which we need to do. So I'm imagining that even though they didn't do a lot of good for him the first time around, that maybe they are now.
They would have, so we finished his procedures. We did the ablation. We did some microphlebiectomy to get rid of his varicose veins, and then we actually continued with the Uniboot until the ulcer was completely healed.
Gotcha.
And then at that point, you're absolutely right. Then you have to transition to some continued use of compression, and compression stockings would be the way to have done that. So we stopped the Uniboots. We put him in basically a knee-high compression stocking, a medical grade, and then we sent him on his way with instructions to follow up.
I was going to say, and we're going to come to that in a minute, but before we do that, I'm going to say that I'm going to ask you that, because I've seen in your office you have these, and I would imagine sometimes for people to just get more proactive on their own that might be listening, what if they just want to get fitted for compression stockings because they think it's a good idea?
Sure. We have a lot of people that come in and ask about stockings, and we fit them, but we always ask them questions to rule out that if they would have an underlying problem. But a lot of people wear compression, not only for compression therapy in general, but for athletic activities and all that sort of stuff. So we got a whole bunch of different styles.
There are different colors, different things and all that. When we come back, after a short little word from the boss, want to let you know about a little bit of the long-term follow-up. Not just for that patient, but for you. What sort of long-term follow-up is there after you've had these sort of treatments?
Spring into summer by looking younger. Call Vein Clinics of Hawaii to schedule your free consultation today. Facial and body rejuvenation procedures are designed to help you look and feel your best without breaking your budget. Reduce pigmentation, fine lines, wrinkles, scarring, and stretch marks with minimal invasiveness or side effects. Confused about which procedure is right for you? Call 427-5565 to schedule an appointment or visit veinclinicsofhawaii.com.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day. While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Okay, now, one of the things we're talking about just before that little pause for the cause was what happens in long-term care. I happen to know once I realized where I was with venous conditions several years back, I realized after talking with Doc that, this is something that you now have to manage. You go past the days, Doc, where you're blaming your mom and you're trying to, have every excuse possible why this possibly couldn't be happening to you. Once you have it, once you realize that it is something that is, I was going to say, it is more manageable than not manageable. So, that's the way I feel about myself. The little things that I do, the benefits far outweigh the hassle of putting on a pair of socks.
Oh, yeah. Definitely.
So what did it indicate? What was going to be the probable, okay, we now have an umbilical with each other. We're going to need to see you from time to time. What sort of follow-up or long-term care in this 68-year-old guy was needed?
Well, typically we like to keep in touch.
Or it's still needed, by the way. He's still doing pretty well.
Still needed. But typically we like to do follow-up in pretty much everybody to one extent or another. And we'll do, an ultrasound usually at about 6 months. And then after that, we try to get people to come back on a yearly basis because it's not like we're curing them of their venous disease.
However, one thing, and I'm glad you said that, and I want you to pay attention, gang, because this is going to be in a quiz. I'm going to give you a quiz. The reason why it's 1 year, you've heard about a lot of other things. The interesting thing about venous disease, and Doc, you've explained this, is that it is slower than many. So that a 1 year you can afford to wait a year after a visit and realize even if something goes on, at least it's going to go on when you catch it. It's going to be next time.
Yeah.
You're not going to have to wait 3-4 years to get something dealt with.
Right. Yeah. And if we do adequate follow up, again, this is just in general in all patients. Then should they need? Or, because we get this question all the time. Say, hey doc, am I going to need all this redone in a couple of years? And the answer to that is no. Especially if we do adequate follow up, we do periodic ultrasounds. If there are new things coming up, we catch them early. And we do we are able to do then sort of minimal sort of procedures rather than having to do all this stuff again. So that's our typical follow-up. Now, that's a routine patient. In this patient who has such advanced disease, number one, number two, has an ulcer that we want to keep a very close eye on. We'd want to probably see them in the office in a few months, just to kind of see them and see how things are going, and look at their legs and make sure there aren't any signs of, ongoing problems or worsening swelling again, or the make sure the ulcerated area is remaining healed. We might see him in 3 months, and we would certainly do another ultrasound in 6 months.
I was going to say, I'm sure there's other of your patients like myself. I am way more aware now. If I get a little cut on my foot or my leg or something, I look at that. I look the next day. If it's not healing, I'm gone. No way to put up with that.
And that's in a patient like this. Who had a very bad problem. That's the mindset that they kind of have to get themselves into, so that recurrence does not occur. But unfortunately, this patient was not in that mindset, and he didn't come back for his follow-up visits, etc. But he did come back about a year and a half later. And it was like we were starting back at square one. He didn't do anything to control ongoing swelling. He came back in. When he came back in after a year and a half, he had tremendous swelling. He was back at that stage where his skin was weeping. His ulcer had actually the ulcer had broken down once again.
Oh, man.
And so, again, we were kind of like back at square one. But we went back to square one. And in addition, he also had stopped some of his medications that he was on routinely, one of which was a diuretic.
I got to ask you, one was a diuretic. I'm like this. I'm like the bad patient, but I'm much better than I used to be, I'm telling you. But I know how frustrating it is. I have a dear friend that's a dentist, and even some of his friends that are patients. He just gets so angry because they just don't get how important it is. One guy was supposed to have surgery on a knee, and they took him out of the operating room because he had an infection in his tooth. And they said, you're not going to have surgery.
Right.
In other words, the teeth bone connected to the knee bone.
Exactly.
So what I'm getting at is that, and I'm sure that this guy felt penitent and sorry, but he doesn't have to apologize to you.
No.
He has to apologize to himself.
Exactly.
And so what do we do to rekindle this guy, or to pick up the baton and fight the fire some more?
Yeah. Well, we actually, the swelling was so bad that we actually admitted him to the hospital.
Oh, my heavens.
And got him back on, because he had a couple of issues. His hypertension was out of control and all sorts of things. So we threw him in the hospital, and just by virtue of him being in the hospital, laying flat and with a leg elevation.
Pretty quick. Yeah.
And then we got, compression stockings back on him. So we controlled his swelling and, again, controlled his general medical status pretty quickly. So he was just in the hospital several days. But then, at that point, then the question for us is why? Obviously it's easy to chalk this up just to, this patient didn't took himself off his medications, he wasn't wearing compression, etc. But we have to be wary of, further venous problems that may be associated with what's going on. So we did another ultrasound, and in this situation, you always have to consider new reflux or, venous insufficiency in another vein, or one of the veins that have been treated already, did that repair break down in one way or another? So that's always a question. We're not infallible.
Yeah, I know a lot of you out there thinking, yes, you are, but no, we're not. And one of the reasons is because it's sort of amusing to me, and you say this a lot. It's a science, but it's not exact.
No.
I mean, things are changing all the time.
Sure.
And not just in the diagnosis, but in the treatment.
Mm-hmm.
So this guy is actually, I mean, you have a lot more control than that. I want to slap the guy's son and say, listen, don't you realize what you've done? But the problem is that they haven't.
Yeah.
And, and maybe once again, this guy's toleration for pain was so great that it just kept coming. He just kept dealing with it.
Mm-hmm.
That's not that bad.
Yeah.
I would go back to the doc. Nah, I don't need to.
Yeah. Well, that's very much a part of it.
Yeah,
sure. Yeah. So we did an ultrasound, and
did he have to get back into the Uniboot? The dreaded
Yes.
Uniboot? Oh, boy. See what happened to you? Now look what we got to do to you.
As your punishment,
Yeah.
throwing you in the Uniboot. But so we did an ultrasound, and the veins that we had closed all looked fine. They were still closed, and there no reflux associated with those. However, we did find now that we didn't see before. It may have been there. We just didn't visualize it. But he had a perforator vein that was large and refluxing right in the area of that ulcer.
Boy.
So
that's like nutrients for the ulcer, isn't it?
It's a rapid grow. So we've talked a little bit about perforator veins in the past, but I think it's a good time to kind of reiterate what they are. And perforator veins are veins that connect the two different systems of veins in the leg. We have superficial veins and we have deep veins. Now, when I say superficial veins or the superficial venous system, those are the veins that you see superficially, like varicose veins and all that sort of thing. Those are veins that are a little deeper in the leg. They serve a very important function. However, there's an even deeper set of veins that we call the deep venous system.
The question I meant to ask you weeks ago when you were talking about this is the ultrasound. Yeah. I do know that the ultrasound is fabulous.
Right.
But it must be the deeper you try to go, the more difficult it is for the ultrasound to work. Can you get a good look at the deep veins with the ultrasound now?
Yeah, absolutely.
Yeah, that's good.
Because that's very important.
Yeah.
I mean, everybody that we evaluate, we look at their deep venous system because the deep veins can also have reflux.
Sure.
They can have a damage or loss of function of those valves. They work with valves, one-way valves too. So you can have reflux in the deep venous system, which is going to maybe alter the way that you're going to handle somebody. We also make sure that nobody has blood clot.
Sure.
DVT. The ultrasound is used all the time to look at the deep venous system, and it gives us a great view. You use a little different probe connected to the ultrasound machine to get to those various depths.
I was looking at an article in paper a magazine about these natal ultrasounds that they're using on babies.
Right.
Unbelievable.
Oh, yeah.
I mean, seriously, unbelievable stuff.
Yeah.
That's how the exponential expansion of the use of these things has happened, right? Aren't they everywhere now?
Oh, yeah.
I mean, any good office has ultrasound.
Yeah, well, many do, but certainly every specialty and subspecialty of medicine seems to use an ultrasound in one way or another. Yeah, it's a tremendous tool.
However, isn't it like a car? I mean, you can have a car driven by 18 drivers. Yeah. Only one of them can get through the swamp.
Right.
And so it must be your guys, your operators, guys and gals. They must be extremely talented.
Well, they're good. Yeah, we've got good ultrasound techs. We're very happy about that because it's the ultrasound. The ultrasound procedure is very, very dependent on the person doing it, very operator dependent. And we're, especially in venous insufficiency, there are nuances in how to show that. So, you got to have a fair amount of talent.
When you get a file from a patient from far away, and some of those tests are in there, are they valuable to you or do you rather do your own?
We usually do our own,
Yeah,
but
I was thinking.
are they valuable? Sure,
Yeah.
because it's always it's always good to know where that patient was coming from. You know?
But the thing that I was thinking just the other day when I was in your office having the treatment, that I don't care how many records you have. The only one that matters is the one you're seeing right now.
Well, that's also true.
Yeah.
And we tell that we answer that question all the time. People who have had things done in the past, they say, "Gee, I'm sorry, I couldn't get my records, and I had some procedures done and all that sort of thing." But
that's all right.
It's okay because all that's important is where that their leg is right at this moment, and we can figure that out with the ultrasound.
I was talking to a friend of mine the other day. And he has to spend many, many hours at night filling in his files that then get filed in his electronic system.
Right.
And he's saying, I don't know why I'm doing this, because sometimes these very files that I'm doing are just the starting point of the next file I do.
Yeah.
I mean, you were here in January. Okay, let's see what's here now.
Right, right. Yeah, it's a double-edged sword, the electronic medical record, but,
Okay, let's get back to this guy that just refuses to see the forest for the trees. Maybe not. Did he wake up a little the second time around?
Yeah.
Okay.
Yeah, he did.
And then what?
So, we diagnosed the fact that he had a perforator. I guess we didn't finish that, but the perforator vein is often found, an incompetent perforator vein is often found right beneath or in the area of an ulcer.
Okay.
I mean, that's sort of a classic situation that we run into. So can we treat that perforator vein in a way similar to the way we treat other veins? Yes, we can. We have a special catheter that we use that we are able to ablate that perforator vein also. So the problem is that there's blood flowing abnormally from the deep vein into the superficial vein. So you got blood flow, coming from a deeper position right up into the base of this ulcer, and it's creating a hypertensive sort of state within the veins around that area, and will not allow the ulcer to heal, or is a reason why it might recur. And in this guy, that was part of the reason why it came back. So we treated his perforator, we ablated it. And we, again, treated him with Una boots until the ulcer healed. And then we segued him into compression stockings with even more teaching and trying to get him to, do the things that he has to. Nobody's going to go to his house and put his stockings on in the morning. There's a certain amount of personal responsibility that, unfortunately, is required, especially in this advanced state of venous disease, so that these bad things don't happen again.
Is he happy that he's getting back to track?
Oh, yeah. He was happy. He was a reasonable guy. He just kind of, lost track of the
It's easy enough. Hey, listen, anybody knows that if you're obese and you lose a lot of weight, people have that yo-yo syndrome. I would imagine the same thing happens with other illnesses.
Yeah.
Sometimes good, sometimes not so good.
Yeah. So, the points of importance here is that, when you have very advanced venous disease, unfortunately, it's unfortunate, but it's just a reality. That is something that you're going to have to deal with for the rest of your life.
Okay, we hope you've had a good time. We hope you've learned something. And if you don't want to be like that guy, get on it right now. Get on to veinclinicsofhawaii.com, www.veinclinicsofhawaii.com. We'd love to see you. And we also would love you to tell other folks about this program. We're really proud of what this program does. We want more and more people to listen to it. And you can also go and check it out at veinclinicsofhawaii.com. Thanks for being here. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day. While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.